stem cell transplant is a traumatic thing. I think it's pretty clear. You end up with, in my case, extreme fatigue and whatnot. And I'm curious as to why it isn't part of the normal process to put a person after that at some point into sort of a rehab, physical therapy type rehab program to get their physical strength back and whatnot.
Great question. It might be institution dependent to some degree. I think we really try the best we can to have patients go into the transplant in as best a shape as possible. And we actually do a lot of prehab, we call it, where we try to really focus our patients as best as we can to do some of that physical therapy as an approach even beforehand. There's different parameters we can look at with different assessments. We have, I'm just saying this word, geriatric assessments, that broadly really do look at very specific components of your daily activities to really get a sense of where there could be perhaps some improvements that could be made. So I think one of the troubles, actually, next thing I would say is that like UCSD, we have a gym in the transplant unit where we have dedicated physical therapists who are designed to see our patients and kind of maintain physical activity as best as we can throughout the actual transplant process. It's a little harder, I think, immediately following the transplants because we want to be so careful about who you're around and what you're doing. We trust no one, to be sometimes safe around you. So what we hope is that prehab and what you've learned in the hospital are then activities that you can do on your own self-directed physical rehab after the fact. But you're absolutely right. I mean, it is a big event that, as a big biased disclaimer, I am a transplanter, believe in transplant. I believe it's an important component of it, that we can do the best we can to try and get patients through it, but there is an obvious recovery time which can help, can really equate to some loss of quality of life that we've seen with trials and in terms of patient-related surveys to say, yeah, my quality of life took a dip, but we can see that then kind of improvement back to some baseline and understand that ultimately we think the benefit does outweigh that risk.
I would just add that I think I completely agree with the prehab. I just saw a patient this week who I'm collecting her cells, but she's barely recovered from all the bone damage and walking. So I think with more time, she's made a dramatic improvement, but I ask all my patients to be able to walk 30 minutes without stopping. Because if you can't do that, this is like a medical marathon. You got to prep for it, right? So if you go in weak, you're going to come out weaker. If you can walk 30 minutes, you're not going to be wheelchair bound when you leave. Maybe you'll be able to walk a little bit less. And the one other comment I'll make is, the reason I was talking about this orthostatic hypotension, one of my first patients when I was in New York left the hospital after a transplant, went home and hit his head. He fell and hit his head. And I don't think we appreciate enough the blood pressure issue, right? Because most people get myeloma in their late 60s and 70s. A lot of people have high blood pressure. A lot of people are on blood pressure medication. Well, guess what? When you first get high blood pressure, what does your primary care doctor tell you? Do you want to start medication or you want to diet and exercise to lose some weight? And so most people end up on medication. But if you're going to lose 5 to 10 pounds in a rapid time from transplant, your blood pressure may be lower than it is. And we only check the blood pressure sitting down, right? So you never check it standing up. So many patients temporarily need to back off on the blood pressure medications, and that could be a big contributor to fatigue. So I think it's something we don't do enough as a healthcare system. And Dana-Farber actually did a study that 70% of patients who go through an auto transplant have this blood pressure drop with standing, and it's not appreciated enough.
Oh, don't be shy.
Can I ask a question too, just about mass spec? So I was talking to Dr. Fonseca, and I know Mayo Clinic has a mass spec testing that they do, so maybe that's why there's a proponent of doing it. But you also talked about FISH testing and how it's part of just a small piece of the picture. So can we just talk about myeloma testing and how you see that evolving? Is mass spec going to take over for the M protein test? And will things like these whole genome sequencing things that you talked about replace the FISH test, which I'm hearing people over and over again now say this is just an inadequate test?
So I think the whole genome sequencing, at least in a lot of the academic institutions, will start to be the mainstay of how we test for the different mutations and different genomic abnormalities that we see in myeloma patients, it'll take a little bit more time before it's rolled out across pathology labs in all medical institutions. But one thing that's being worked toward is to really reduce the cost and really improve the turnaround time of these so that it can be more accessible. And I think with other cancers, a lot of these pathology labs already have experience sending these tests off for genomic testing. So I do think that that's going to be the next wave, and likely, I mean, depending on who you talk to, like if you talk with Dr. Fonseca, I don't know, maybe he would say FISH would stick around because he was kind of one of the pioneers of it. I think it'll probably replace it in the relatively near future, especially with the new guidelines advocating for it over the current testing. I don't know if anybody else has a comment on it.
I agree. I think FISH is like a landline, and the next-gen sequencing is like cell phone, right? It's just, but it's expensive, and we need to get it pairs. But there's a lot of information that you get, because the limitation is FISH is you can only get information for the probes you're testing. It doesn't tell you about anything else. And we now know, for example, the risk of other blood cancers might be picked up by these next-gen sequencing, and also mutations aren't picked up, right? So like if you have a 17p, the new high-risk criteria is not just a 17p loss, it's a mutation. You're not going to get that from FISH. You need the genetic sequencing. As to the mass spec, I think there's blood-based testing is SPEP, IFE, and light chains. I think mass spec will make SPEP and IFE obsolete because that's labor-intensive, and it doesn't tell you whether it's a myeloma or the antibody that somebody's getting, right? So many of you know that any IgG kappa antibody will interfere with an IgG kappa myeloma patient's detection. Mass spec will help us differentiate that, and you don't need to do multiple tests. Where it's lacking, though, is light chains are not as well yet picked up by mass spec. So I think light chain patients will still need light chain till we can improve on the mass spec technology. But I'm a big believer in mass spec. I try to do it in all my patients. It's a send-out test to Mayo, but in anybody who I'm doing a marrow for MRD, I'll do the mass spec, because if it's positive, why do I need to do an invasive procedure on the patient, right? If the blood is positive, that's more believable than a random biopsy in the marrow. So I always say that, like, when I tell my patients, to me, a bone marrow is, are you getting an A+, right? If you're at an A-, why do we care about an A+? Like, if you're getting an A, I want to know if you're A+ from the MRD. But if you're anything less than an A, blood-based test, you already have your answer. You're going to be MRD positive, or the test is bad.
That sparks a whole conversation about just blood-based versus bone marrow-based type testing. Do you all want to weigh in on where you see that evolution going?
Well, I think when it comes to testing MRD, I think bone marrow is going to be more accurate than a negative peripheral blood MRD test, for instance, with clonoSEQ. I don't know if with newer technology that'll change, and I think that's the hope, right? Like, to have an effective MRD test, you want something that you could test regularly and non-invasively if you want to do early detection. Otherwise, we're doing marrows, annually or even more frequently than that. But where I think it's going, hard to know exactly what the next steps are. I don't know if you have thoughts.
Any other comments from Dr. Costello or Dr. Goldsmith?
I know what we all want. We all want to get rid of these bone marrow biopsies. I think there's been, many different companies have looked at trying to get away with bone marrow biopsies and get what we can out of the blood tests, and many of them have unfortunately failed. I think it's perhaps part of the disease. It's for the most part, a marrow-borne disease. And so by doing just blood-based testing, I think we're missing the roots of the problem sometimes. We can get very, very, sensitive data with mass spec as an example, to find that 0.001 little piece of an M spike that's hanging around. I worry that it's not going to be enough.
Shameless plug, but for people who are going to stem cell collection or transplant, we generally do a bone marrow biopsy beforehand to reassess where their disease is. We're going to be opening a study where we're going to take patients who are getting that bone marrow biopsy. We're going to do clonoSEQ, next generation sequencing on that bone marrow, And then when they go through their collection process, as they're getting mobilization agents to collect their stem cells, we'll be doing peripheral blood clonoSEQ on those blood tests as well, with an interest in seeing, instead of going to where the plasma cells are in the bone marrow, could one bring the MRD test into the peripheral blood using those mobilization agents? It's kind of just a weird question that I had for a while, but could open an idea or the door toward peripheral blood MRD testing in that fashion. So, like I said, shameless plug. We'll let you know.
No, I think it's so important to know that if you can confirm that that's the same, then why bother? So.
Right.
I'm going to ask about the cell mods. You talked about the cell mods that are coming down the road. When do you see those coming down, and how would that affect the sequencing of like CAR T and BiTEs and things like that?
That's the million-dollar question, probably multi-million-dollar question. I think there are a lot of advisory boards that are talking about those exact things right now. Some view the cell mods as being replacements for the current, potential replacements for the current IMiDs. Maybe iberdomide replacing lenalidomide, maybe mezigdomide replacing pomalidomide. But then there's the question of saying, well, these drugs are still active even for people that have experienced those drugs and then had a progression. They could then maybe receive mezigdomide afterward. We do have data that that's possible. So in the idea of having as many myeloma therapies and as many things to sequence in this marathon of treatment, would it make sense to save it until later? And I think there's a lot of debate on to where that will be. I think part of it, a lot of it actually, to me, will depend on what the side effect profiles look like in comparison to the drugs that are currently out there. If they prove that they're as effective or more effective but better tolerated with less of the side effects that we classically associate with Revlimid, then they might end up being a replacement. So I think it kind of remains to be seen when we get these larger phase 3 trials, the results from those soon, or hopefully soon. As far as the sequencing between CAR T and bispecifics, that also is unclear, but as Dr. Chari alluded to in some of his talk, doing back-to-back bispecifics or doing back-to-back immune therapy, you might be losing out on some of the efficacy. So a lot of providers have been talking about putting something in between, such as a CELMoD-based regimen, which also has a little bit of data on changing the immune microenvironment or changing the immune system, and maybe reducing some of the T-cell exhaustion markers that you would see, so that you can not only get the anti-myeloma effect, but also prime somebody for their next treatment, which could be another immune therapy after that.
Just add, I think, I have to say, full disclosure, I've always been a skeptic because it always seemed like iPhone updates, right? Like, do you need the new one? And it always seemed like you'd get a new CELMoD or IMiD right when the previous patent was running out conveniently, right? So I was a little bit skeptical, but I think they're a very important drug class. If I had to predict, I would say Revlimid will be very hard to replace because it's approved globally in frontline therapy and maintenance. And if you're going to give Revlimid for up to 4 years, 5 years, and you're getting a new drug that's going to be priced this high, very few countries will allow that replacement because you got to have a major additive efficacy or safety difference to say that you're going to pay thousands and thousands of dollars more per month per patient globally. So that's a tough barrier. Pomalidomide is going to be much easier to displace because if somebody progresses on Revlimid, at most the regimens with POM are giving a year. So now the CELMoDs could easily displace that. I think the problem with if the CELMoD studies had been done in 2016 or earlier, I think they'd be on the market now. The problem is they came to the market right when immunotherapy came on. And so then the FDA has this benchmark that to have a single agent approval in unmet need, you need to have about a 20 to 30% response rate for about 3 to 4 months. But now these new drugs have blown that out of the water, so it's kind of hard to know. And so the health authorities, both in US and Europe, did not allow them to be approved on the basis of a single-arm study. They're going to have randomized phase 3 studies with 2 arms. So until those read out, you're not going to have access to that commercially. So that's why we're in a bit of a treading water space. But I don't know that the neutropenia problem is a big one with these drugs. So it's not like if there was much less neutropenia, you'd be easily able to replace Revlimid and pomalidomide, but they have if the same, if not more neutropenia. So I think we'll have to be thoughtful about combinations and sequences. But I agree that giving the T cells a break between going from CAR to CAR, bispecific to bispecific, might be one of the roles for these agents.
Hi, thank you. Thank you for being here and doing this. We're new to this whole thing. We are with an HMO, Kaiser as a matter of fact, and we live in Los Angeles, and the doctor told us that she only sees about, she's an oncologist, and she told us she only sees about 8 myeloma patients in a year's time. This one black man and a bunch of Jewish people. And she said, I'm hearing you say on your team, get an expert on your team. How do you go about getting an expert on your team? That's my question. How do you go about building a team and getting an expert on your team?
You can probably speak to this, Scott, being in the LA area and being associated with City of Hope.
Yeah, so I see several patients who are within the Kaiser system, and then they schedule a consult, and many of my colleagues do as well. And then there are some bone marrow transplant physicians within the Kaiser system that do the bone marrow transplant in City of Hope and in Kaiser in LA, who do have a focus more in multiple myeloma. Dr. Firuze Sahibi is one that I can think of offhand, and we work very closely with her. So if it's something where you can ask your provider if they can help you get a consult with her, that she's excellent and within the Kaiser system and very myeloma focused.
Can somebody talk about how patients can work with you for consults and then go back to their local center and get their infusions? Because with traffic or with distance or with all those things, that's a big issue for a lot of patients. Rural, urban, doesn't matter.
We actually encounter this scenario a lot in Seattle because we receive patients from Idaho, Montana, Alaska, who can't feasibly come back and forth for treatments very often. And nor should they, right? I mean, especially if they're receiving standard of care therapies, can usually get them with their local team. But we do like to stay connected with patients as a consultant, and we'll see patients maybe once or twice a year, depending on if there are questions. But I would say the other big benefit of staying connected with a myeloma specialist is if there comes a day where you have disease progression and need clinical trials or CAR T or transplant, it's somebody that you could really easily reach out to. And so I would encourage you to stay connected, but you don't necessarily sever your relationship with your local oncologist. We can usually work together.
And usually if you're trying to do that, it's better to have a medical record at the facility and be a patient there, so you can just say, okay, it's time to make a treatment choice. But every time you're making a consult treatment decision, it's better to be talking to one of these individuals.
I would just add that
To go along with the question, my wife has amyloidosis as well as multiple myeloma, and when we went, her original oncologist had only ever seen one patient, kind of the same situation with that disease. Well, my wife went online and researched, clinical studies, and ended up in a clinical study in Stanford where they paid to bring us up there, especially for the initial treatments. But that person, amyloidosis was their specialty, right? So by going through some, go online, try to find clinics, talk to your doc, or clinical studies, talk to your doctor, see if they can find some. And then Kaiser was actually very good about working with the clinical study and paying for the standard of care, I guess, as well. So you can do it that way.
So I was just going to add, I think in Bay Area also we have a lot of patients with Kaiser, and so we do the same thing. One time, it is self-pay to do a consult, but you don't have to do this every time, right? So I would say the important junctures are initial diagnosis, because sometimes, and whether or not to treat, particularly smoldering myeloma, that's an important decision that should be, I would recommend. And then at junctures of therapy, transplant, maintenance, or side effects. If you're having a lot of side effects, that's another time to speak to somebody about discontinuing. Some of the other things you could do are do virtual visits. I would say, California is a huge catchment area. Our patients come all the way from Oregon to Nevada, and I do a lot of virtual visits. I have I'd say 80% of my clinic is now video visits. But the rule for video visit currently, this could all change, is the patient needs to live in a state where the physician is licensed. So as long as you're in California, for example, you can see anybody who's licensed in California. Or sometimes we say, if you say you're in California, right? But then you just have to come, at least if you've seen, we also have a rule that if somebody's been seen at the cancer center once, and then they're in a different state, we'll let them continue virtual visits. But those are some other strategies. And then that clinical trial, I think just the challenge with clinical trials is the way clinical trial payments are worked is that there's a standard of care component and a research component. Standard of care component would be routine blood draws, marrows, and scans. Those are billed to your insurance. The research component is the drug. That would be free of charge. So the challenge with Kaiser, and it's very study specific, is if your Kaiser would have to pay for all the standard of care testing at the academic center. So that can be a little bit tricky. But it's navigable. It's worth looking into.
And we have a myeloma specialist directory on our website. So if you have other friends or patients who are looking for a myeloma specialist, they want to search by location, they can.
I have a question about Revlimid, and you had said if you take it for 4 to 5 years, and both my I was on a webinar and heard this concept, and so I took it to my local oncologist and my bone marrow transplant doctor, Samara, in LA, and I'm in Kaiser also, and they both said, no, we'll stop it at 2 years. So can you speak to Revlimid and the length of time?
So the initial studies so after transplant, half the patients got maintenance, half didn't. And what that showed is the patients who did not get Revlimid maintenance had a 2-year remission, and with Revlimid maintenance, that doubled to 4 years. And importantly, people lived longer, which is why we prescribe it, because the alternative to doing maintenance is just be off treatment and treat when you need to. But the living longer suggests that the myeloma benefit is important. And of course, we can talk more about it, but there's a secondary cancer issue as well. But your specific question, the initial study, there was a study in the US which looked at, did it seem to matter how long you were on Revlimid? And that was a retrospective study, and it suggested that people who stayed on it longer did better, actually. So what you're referring to is this year at hematology meeting, there's a study from Greece where they looked at patients who were MRD negative at 2 consecutive time points, and after 3 years, they seemed to be no additional benefit. And so that's probably the most recent prospective data that we have. And the reason this is important to do is if you do it retrospectively, people who do well are, people who do better always do better, right? And the people who don't do, so there's a lot of confounding variables, like people who had side effects might have stopped, people who were high risk continued, but they didn't do as well as you would have liked. So there's a lot of biases in doing retrospectively, so the right way to do this is really prospectively, and there's many studies going on to discontinue, and this is perhaps one of the best use of MRD, right? That we should be trying to discontinue therapies, and we don't talk about it enough, but we probably cure about at least 10% of patients with myeloma. But if everybody's continuing therapy indefinitely, how do you identify those, right? So I think one way to do that in a thoughtful fashion is you take the patient's risk. If this is a standard risk myeloma, favorable disease, and if they're persistently MRD negative, it's reasonable to have this discussion. And then when you add to that toxicity, if anybody's having even a whiff of really debilitating fatigue, diarrhea, rashes, or blood counts are low, then it's reasonable to have that discussion about discontinuing.
Hi, I am one of a team of moderators of a myeloma support group on Facebook. People come to us often when they've just been diagnosed or they're about to go and see a specialist for the first time. And often a question that gets asked, this is one of our greatest hits, is what should I ask when I go to see the specialist? So I'm going to ask you, what do you wish patients would ask you when they come to see you?
I'm going to start here because I spend a lot of my time on an initial consultation just teaching patients what myeloma is, because I think it's very easy for us to sit up here and say, do this, do that, but we are developing the beginnings of a partnership, which wonderfully is lasting a very long time now with a patient who's newly diagnosed with myeloma. And so I want to empower my patients to know the method to my madness, right? To understand very basic. So I want every patient to know what myeloma is. Broadly, it is a cancer of this plasma cell. I want people to know what their type is, IgG kappa, IgA lambda. I want them to understand what lab parameters I'm watching, that prompts my decisions. I want patients to understand their risk group and how I identify that with FISH findings or sequencing, for example. So I think a lot of the diagnostic details are just essential for patients to understand and will help them also track their progress along their journey as well.
Yeah, it also kind of depends on whether they're coming to see me and establish and stay under my care, or it's something where I'm going to be working with a community physician and they're just coming to get an understanding of things. If a patient is going to be with me for a while, I'll likely keep it just to like the beginning stages of like what to expect, side effects relate, exactly what Caitlin said, like giving them an understanding, reassuring them that it isn't something that they did in their life that led to this. This is a sporadic cancer that happens because these cells normally undergo mutations, and every now and then one of those mutations goes wrong. I want them to be assured that it's not anything that they did and not anything that they need to make major lifestyle modifications to try to adjust for. And then if they're staying with me, I'll likely just talk about the initial stages and say, we're going to talk about these other things at a later time point, like transplant and everything like that. But I try not to feed them with a very, very large spoon up front. But if it's somebody that I'm only going to be seeing once every few months, then I will break out a piece of paper and write down the different phases of treatment, whether they're deciding on whether we think that transplant is in their future. We'll also talk about if there are any clinical trials that they're available. They should ask about, are clinical trials available? What is a clinical trial? What does that involve? And that sort of thing. I think those are kind of it kind of depends on how much we have to fit into that one time frame, but try to break it down into different chapters that they can expect and what they can expect from each chapter.
And Dr. Kwok, you were going to say.
Oh, yeah. I mean, that first visit is so much information. I mean, today we covered treatment and diagnostic workup, but we didn't talk about, you have to see the dentist because we're going to start a bone strengthening medication, or introducing clinical trials, which they kind of have to decide quickly if it's going to be a trial for a newly diagnosed patient. Sometimes that's people want to table that for later, but once you start treatment, sometimes then you're ineligible, right? And so I would, if people are reaching out to the support group, I would encourage them to, first of all, bring another set of ears with them. And then, not be afraid to write things down or even write their questions before showing up to that first visit, because it can be quite overwhelming. But also to reassure them that in myeloma, I feel it's people bring spreadsheets and, we talk about the same thing month after month. What is your M spike? What is your light chains and symptoms and things like that? It's very cyclical. And so reassuring them that eventually, they too will become myeloma experts, And so, sometimes I think having that expectation is super helpful. But also, I would encourage them, if they ask, to be willing to talk about clinical trials.
And if you ever want to talk to our patient navigators and have them help you prep questions for your upcoming appointment, we have patient navigators that you can get on the phone and do that with.
I would say just my 2 cents. I remember one of my medical school electives was called "Is it cancer and can I still have sex?" the 2 questions that patients had and were afraid to ask. And in that class, you learn exactly what Dr. Kwok just said, that 50% of the information in a new visit goes in one ear and out the other. So it's really important to have a caregiver, especially because we have to go through all of these things like laboratories, staging, prognosis, bones, kidneys. And so it's too much information, but we only get a limited time with the patient. So we have to deliver all that information. And so it can be overwhelming. So having a second set of ears or recording the visit, I think is really a good thing. And the second thing is kind of asking what you just asked. What should I be worried about? Some of my patients are so worried about like 4 steps away. And I'm like, can we just focus on today? Like today's thing is you need to walk more. Let's see if you can get off your narcotics because your myeloma is better and your pain's better. Like kind of not the random MCV laboratory that's on your blood test, right? I think the dangers of these patient portals is the scrutiny of all these labs, and it's, as a patient, if you're newly diagnosed, you don't know what of that is important, and asking your doctor, what should I be looking at, right? And what's my most important goal? And I think, and the last thing is kind of like this existential kind of coping with this, right? Like, how do you have hope that this is we are curing 10%, but how do you deal with being told you're high risk? What does that mean? I think there's that kind of psychological coping that I think is the most challenging, and that's what you really want the myeloma expert for, because the doctor who's seeing 3 patients a year is not going to be able to deliver that really 360 perspective on that.
You just mentioned 10% cure. You guys have done phenomenal work, and it's improved tremendously. What is the prognosis? When you say cure, I mean you like cure? Like permanent cure? Which is phenomenal.
There was a large data set from the International Myeloma Working Group. They studied thousands of patients and found that about 10 to 15% of patients remain treatment-free off therapy. And who those patients were typically favorable stage, right? ISS1, favorable genetics, younger patients who got transplanted. But that's old data now, right? We may have a whole new set of cures that we don't even appreciate because we need longer follow-up. As I was alluding to earlier, if CAR T patients haven't relapsed in 5 years, might we be seeing a cure? We don't know yet, right?
Because they used to say only 10 years.
Yeah, because cure has different definitions. It's undetectable disease or being off treatment or both, right? And sometimes maybe you don't have treatment, but you have a little bit of disease left, but that could be a functional cure. And so it really depends on how you define it, but the point is we need to strive for it, and many of us in the field are saying if we don't talk about it, we're never going to get there, right? And we should reject journals in papers that say this is an incurable disease, because we need to move forward and be optimistic and give patients hope. Not oversell, right? Like, because 90% aren't being cured, but at least give people that hope and try to work towards increasing that number.
So you see that number, that 10-year number might be way off.
Yeah, we want to be proven wrong. Put ourselves out of business.
Yeah, good for you guys.
So my question is, so let's say you're evaluated in the beginning and you're a potential stem cell transplant candidate. So that's decided. But then they're looking at numbers to see when you get the green light to move forward. What specifically are they looking for in your lab results or bone marrow? Like, at what point do they say you're ready for this now? And what are some of the tests that you do that indicate that? Do you understand my question?
I think I'll take a stab at it, but I think what happens in clinical trials and what happens in practice might not be the same. So sometimes clinical trials will say that there are 3 or 4 cycles of initial therapy followed by a stem cell transplant. At our center, we try to get people to a very good partial response, a 90% decrease in their monoclonal protein before doing the stem cell collection. So frequently it does involve maybe a couple extra cycles of treatment if they're not there yet. And so those are the big goals. And then we also have a lot of kind of check boxes that we're looking for. So for instance, sometimes these are self-imposed, like making sure cardiac function is adequate, pulmonary function is adequate. If there's like if someone's on, say like therapy for metastatic breast cancer, that's not probably an optimal person for transplant. So there are certain things that we look for. And then there are certain things that the insurance companies will also have us look for. So to make sure that the colonoscopy is up to date and that the dentist said it's okay, and certain things like that that kind of need to be checked off before transplant.
But as far as the M protein number, there's no specific, like once you get below 1 or.
Yeah, we typically look for a 90% decrease, but that might be unique to our center.
So one of the interesting things about practicing on this side of the Atlantic is we can do whatever we want, right? So like in clinical trials about this specific topic in Europe, they're fixed in what they can give. Often it used to be Cybord-D, which is Velcade, Cytoxan, Dex, no Revlimid. What that means then is that the transplant was more important, the consolidation post-transplant was more important, everything was more important because they got such limited therapy. That same study in the US was like all over the place because we didn't show any benefit of a second transplant or consolidation. And so I think what you're seeing is American physicians have the luxury of tweaking things. So what I like to tell my patients is I want everybody at the end of transplant to get that A+, right? So that MRD negative. So patients kind of tell me in a way how their disease is doing, right? So if somebody's responding beautifully and they've gotten to very deep remission and you're not seeing any incremental change, then go ahead and do the transplant. Or if somebody is not responding to therapy as well or having a lot of side effects, then move forward with transplant. If somebody's having a slow, steady response and still detectable disease, I'd keep doing it as long as they're tolerating it, because then I'm going to use the transplant to get them to that A+, so that we can use less maintenance therapy post-transplant, less consolidation. So my goal is like A+. I want no detectable disease post-transplant and have to use as little therapy post-transplant, avoid consolidation post-transplant, and maybe even do single drug maintenance as opposed to double drug, but all of that. So I think it's really very patient-specific.
Okay, we'll do 2 more questions, one here and then one here.
Well, I had 2 questions, but I'll only do one. I'll make a statement and then I can ask my question. I hear that urine protein analysis is no longer needed. Is that true?
There was a meeting in Paris that this will be no longer an important part of clinical trials. I think where you might still see it being used is in people who have low proteins, where you can pick up albumin, right, low albumin, or in people with kidney dysfunction where you want to be able to trend it. But in the everyday myeloma patient, I don't think we're going to be torturing you with 24-hour urines as much. So
thank you.
Hopefully you'll cope.
Yay, that's huge. Okay.
So Dr. Kwok mentioned earlier that you try to get in a prescription for DARA, for that new trial that just came up recently.
Yeah.
And it didn't go through. Is there a way around that at all? And then also, my second question is, and please excuse my ignorance, I don't have a clinical background. When you're trying to get, when a patient is newly diagnosed and you give them their first line of therapy to reduce their cells so that you can get their cells when you're trying to clean out their body, right? You go through this, you pull out their stem cells, and then you take them to get done. Why don't they, if a patient has smoldering myeloma, why not pull their cells then before they progress to myeloma? Am I making sense?
So in regard to like the autologous stem cell transplant, like where you are taking a patient's cells out, giving them chemotherapy, and then returning the cells to them, the main purpose of that is really the anti-cancer effect is the chemotherapy. It's the giving of the high dose of chemotherapy that's killing the cells. When we take the cells out of a patient, when we do the harvesting, if you will, we actually don't do any like manipulation, any filtration of the stem cells themselves to take out the myeloma or anything like that. It's really, we're taking those cells out because if we kept stem cells in the body when we gave this chemotherapy, those cells would all die. So we take the cells out, give the chemotherapy, and then the cells go back in and rescue the body. They allow for the production of blood again. So in your question about why not do it with smoldering myeloma, there's some concern about, their myeloma might be at a higher level at that time. And then most patients, and so when you were to collect it, because the myeloma is at a higher percentage when somebody has smoldering because they haven't gotten any treatment yet, the thought being that maybe it comes along with the stem cells. I don't think that's necessarily proven out, but we haven't done those studies to really know. The other aspect of that is that there are many, many people with smoldering myeloma who actually won't need treatment, depending on their risk of progression in that standpoint. So we'd be putting those people through procedures and medications and other things that they wouldn't necessarily need and could have potential side effects.
And regarding insurance denials, there's a whole process to do an appeal and to try to have a drug approved. I think it's a little more challenging in smoldering myeloma because the alternative is observation frequently. And so to make an argument that, this is a mandatory type medication is a little bit more challenging to make, albeit there's, some promising data about its use in high-risk patients.
Okay, we have a very short question.
Yes, I have a very short question. What is smoldering myeloma?
I'll do it. All right, so a very brief answer is that everyone who has multiple myeloma did not go from some state of nothing to some state of myeloma overnight. There is a precursor or the beginnings of multiple myeloma that from one day, a normal plasma cell, the bad guy in this scenario, went rogue and over time copied itself. And as there becomes more of a critical mass of those abnormal cells is when it could perhaps do damage to the body. So before you have myeloma, it started off as what we call MGUS, MGUS, monoclonal gammopathy of undetermined significance, which means we don't know why, we don't know if we care, but there's something there. But we do sometimes care because a little bit of something can turn into a little bit more of something. Yeah, it's the beginnings of the cancer, I'd say. And a lot of the discussion surrounds around the thought is that we wait for people to develop myeloma, but a lot of controversy recently is to say, well, why wait? Why can't we kill this thing before it becomes something? And just as Scott mentioned, there's lots of reasons why not to. Perhaps there's some reasons why to, as long as we choose the right person to do it for.
And the right treatment, right? It's this risk-benefit ratio that you're trying to evaluate all the time. Okay, let's give everybody a hand.